good afternoon, or good morning. I'd like to welcome you to today's webinar hosted by the Hep United Coalition. The coalition, a national coalition co-chaired by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. We work across the United States to increase hepatitis B testing, vaccination, and linkage to care. My name is Kate Morars. I'm the Deputy Director of Public Health with the Hepatitis B Foundation and Director of the Hep United Coalition, and I will be your moderator today. Before we get started, I'd like to navigate you to some ways to participate in the webinar. Remind you that as an attendee during today's webinar, you'll be in listen-only mode. If you encounter any technical difficulties online with computer audio, please feel free to dial in using the phone option on your control panel with the conference line shown here on the screen. And at any time during the presentation, please feel free to enter questions into the Q&A box on the right-hand side of your screen. Questions will be addressed by the speakers at the conclusion of the presentation. And if you also have any technical challenges, please indicate your issue in the Q&A box as well. So today's webinar is focused on improving hepatitis B treatment access. Right now in the US, and I know we have a global audience joining as well, in the US, we are nearing the end of the period where individuals can sign up for the health insurance plan for the year 2020. We actually have a few days left, and we hope that this webinar will be helpful for those who are looking for the best plan, especially for those that offer access to hepatitis B medication. And we will also focus on things that people should look for, as if you're also a patient navigator, helping your patients look for the best plans, things to keep an eye out for when it comes to certain discriminatory practices that may be implemented by health insurers. And I will go ahead and introduce our speakers today. First, we will have Michaela Jackson, who is with the Hepatitis B Foundation. Michaela is our Public Health and Outreach Program Coordinator. Michaela will be covering some of her research over the past year that looks at health insurance plans and access to hepatitis B treatments. And then following Michaela, we'll have Rachel Klein, who is the Health Policy Manager with the AIDS Institute. And Rachel will be sharing some analysis of other aspects of health insurance plans that her organization has been focusing on. Okay. And I'm going to go ahead and turn it over to Michaela to kick us off.
Thank you, Kate. So as Kate mentioned, I was working on adverse drug sharing practices in the United States. And today we're going to talk a little bit about what we've really been into in the 14 states that we've analyzed, as well as just some background information to help everybody really understand this discrimination that's been occurring. So next slide, please. As a little bit of overview, which I'm sure many of you know, hepatitis B is a viral infection of the liver. In the United States, it disproportionately impacts Asian Americans, Pacific Islanders, and African immigrants, although we are seeing a rise in acute hepatitis B in the United States due to the opioid crisis. So Asian Americans make up about 50% of the chronic hepatitis B infections in the U.S., which is really significant considering they only make up about 8% of the U.S. population. And some things to note are that for hepatitis B, medications need to be taken daily. So stopping suddenly or taking it only sporadically can cause virus to flare and increase one's risk of liver disease, liver cancer. And if left untreated, 1 in 4 will suffer from liver disease or liver cancer. Next slide, please. And so how we really got into this issue is that as a Hepatitis B Foundation, we receive thousands of consults each year through the phone, social media, and emails. And what we've really noticed was that in the past year or so, we've seen a significant increase in U.S. calls about accessing their medication. And medication access calls now make up about 10% of the phone calls that we receive. And so who are we hearing from? We're hearing from nurses of patients, family members calling on their behalf, the patients themselves, parents who have children living with hepatitis B, and retirees who necessarily don't have the steady source of income that other individuals might have. And they're saying that they've had to pay $4,000 deductibles before any sort of cost sharing kicks in. We've had individuals call with $1,200 a month just for copay for medication access, $2,400 a month, and even for almost $500 just for generic medication. And so that's when we really noticed that something wasn't quite right here and what was occurring, and we decided to look further into the issue. And what we found was that adverse drug tiering was occurring. So next slide, please. What is adverse drug tiering? So basically, it's unfair ways for insurance companies to place the cost of medications onto the consumer. And this is quite a light definition for what can actually be occurring. But it kind of encompasses everything that we'll be talking about today. And so the key takeaways about adverse drug tiering is that it is illegal. It's discriminatory against people living with chronic illnesses. So it doesn't just happen with hepatitis B, although that's what we're focused on today. And it's typically done through hidden benefit plan designs. And that's important to note because it's not jumping out at you, this discrimination. And many people don't realize it's occurring, and they just kind of accept it for what it is, believing, oh, well, this is just the way that the insurance plans work in this country. I have to do what I have to do. And so that's not really what the case is. Next slide, please. And so some examples of adverse drug tiering are co-insurance rates, generic treatments with high cost shares, mandatory physician's approval for first-line treatments or generics, and placing most or all of the hepatitis B treatments on a high tier. And so that last one is pretty significant because the higher the tier is, generally the higher the cost is to the medication. And so say, for example, we're looking at a plan that has 1 to 4 tiers. Tier 1 will generally be the lowest cost, and that's usually reserved for generic treatments. And tier 4 will be the highest tier, which often has the higher cost, and usually reserved for specialty treatments. And what we've been seeing a lot of, we're seeing generics on these high tiers. So generics being priced at the same price as a specialty drug or more. And so we know that's not right. Next slide, please. And so how do we know that these actions are illegal? And we know this through consumer protections that have been instated on the federal level. So both the Americans with Disabilities Act and the Affordable Care Act recognize hepatitis B as a federally protected illness, and they also protect consumers from these illegal benefit designs. And so federal law states through the Affordable Care Act, essential health benefits, which is Section 1557, that it's illegal for companies to include a benefit design in their current plan that discriminates against individuals based upon age, race, disability, gender, health condition, and a number of other factors. And so that little graphic is just a great reminder in the corner that the essential benefit design of the Affordable Care Act makes what is occurring illegal. Next slide, please. And so before we really get into our analysis, I just wanted to provide a little bit of background since insurance terms can seem kind of straightforward, but can be a little bit confusing. So cost sharing is essentially just the cost of treatment with your insurance company. It's sharing it. That's all that there is. For co-insurance, it's the percentage of the cost of the medication that a consumer must pay. So the example that I used was 30% co-insurance of $830 is $249 a month. And so this is for entecavir, which is the average price of it is $830 in the United States. And so if we're looking at the co-insurance rate instead of a copay, generally co-insurance you will have to pay more. And so for a copay, the set rate is you pay for medication no matter what the cost is. So for example, you'll be paying $15 a month for entecavir $20 a month, but you won't get to those high numbers typically, like $249, $300 a month. Next slide, please. And a few drug definitions. So a brand name treatment that we'll be talking about is just the FDA-approved treatment that receives the first patent for its creation. A generic treatment is created to be the same as the brand name drug in strength, performance, and quality. The main difference is that generic drugs will be cheaper because they don't have those initial startup costs associated with them that a brand name drug would have for the research to create the drug. And a first-line treatment is one of the treatments that is preferred by both the doctor and consumer for effectiveness and its lack of side effects. And so these are the three drug types that we'll really be focusing and honing in on today. Next slide, please. So our methodology and our analysis was based upon a summer analysis and successful policy actions that were taken by the AIDS Institute and the National Law Health Program back in 2014, and specifically for HIV treatments. And so what was happening was that insurance companies were unfairly forcing customers to pay out-of-pocket costs for HIV treatments more than they should have. And so they conducted an analysis of a few states, and they brought it to the attention of specifically Florida's insurance commissioner and the insurance companies. And when enough action wasn't taken with the insurance companies, they sued and they won and found out what was happening was indeed illegal. And one thing that I really wanted to point out, which is just very interesting, is that tenofovir, which is an HIV treatment, is also a hepatitis B treatment. And now what we're seeing is that tenofovir, which is also a generic, is typically on those lower tiers with low prices. So we'll see it on tier 1, maybe tier 2. However, what we're seeing with entecavir, which is a hepatitis B treatment, often on tiers 4 or 5 in some states, so associated with those higher pricing. Next slide, please. And here's an example of what we really looked at for these states in our analysis. So we examined states that were specifically on the federal exchange because that means they're protected by those federal laws, FDA-approved treatments, of which there are 12, and the silver level plans as those are the most popular for people. And so this is a really good example of a bad plan. If you look, tiers 4 and 5 and even 3 have 50% co-insurance rates for the treatments, and we're looking tenofovir, which is at TDS, is on tier 2 with a $20 copay, and yet entecavir, which is a first-line treatment, is at 50% and considered a specialty drug. We also looked at restrictions, what drugs weren't covered by plans, and how long they were covered. Was it 31 days? Was it 90? Next slide, please. And so this slide just depicts the 3 first-line treatments. So 2 of them have generic, so tenofovir is TDS, and entecavir, this is generic versions of it. And Vemlidy is a pretty recent drug. Its patent has not expired yet, and so it does not have a generic. Next slide, please. So this is a breakdown of what we found. So we analyzed 14 states with 81 insurance companies on the federal exchange and 205 plans in total. And so for the first graph that we're looking at, or the chart, excuse me, we're looking at specifically hepatitis B generic drugs that are placed on insurance companies on either a high or low tier. And specifically, we're looking at least one generic drug on a high tier. And 72% of the insurance companies out of the 14 states did that. And the second graphic that we're looking at are insurance plans that have co-insurance rates, so those percentages on the high tiers. And 69% of the plans that we looked at did that. So it's very clear, just based on this, that adverse drug tiering is definitely occurring across the United States. And if we move to the next slide, we can see a breakdown even further of the states that they're occurring in. So the left, you'll see all the states that we analyzed. And this is specifically looking at the generics that are on those high tiers. And so the states that we're highlighting in red, we're calling out because those states had every single company that was on the exchange had a generic and a high tier. And even if you take a closer look, we're looking at more than half of the companies, usually in these states, have generics that are high tiers. So these are some pretty significant numbers that we're looking at. Next slide, please. And here we're looking at the state comparison of the plans with co-insurance rates. And we can see that there are even more of those in the breakdown. So actually half of the plans that we analyzed included this. So California, Georgia, Hawaii, Minnesota, New Jersey, and Texas all had plans with those co-insurance rates on high tiers, every single plan in that state. And so those are also some pretty significant numbers. But again, if you look closer, like Illinois, 30 out of 34 included that. Pennsylvania, 13 out of 14. So we're definitely seeing this discrimination occurring. Next slide, please. And if you want to take an even closer look at factors that influence somebody's treatment access, you can look at the deductibles. And so if you're looking at this chart, 52% of the plans that we analyzed, out of the 205 plans, had a deductible over $3,000. And it looks a little skewed on this graph, specifically because New York and Illinois had the most plans in their state just because they're so large on the federal exchange. But the breakdown, if you actually look at the numbers, is very important. And so the reason this is significant is because many individuals paying $3,000 out of pocket up front for their treatment can sometimes be the price between paying for the housing and paying for the medication. This is a life-saving treatment, and we want to keep that in mind. And so another reason this is significant is because with the people, so these deductibles often have to be met before any sort of cost sharing kicks in, before they can get that copay, before they can get that co-insurance rate, and then they're paying on top of that. Next slide, please. And this is kind of reflected in our general findings again. So the first one is that there was a general trend of requiring deductibles to be met before those cost sharing began on high tiers. There's a copay for lower tiers and co-insurance rates for higher tiers. Benchmark plans, which are the standards of what should be met as a bare minimum by insurance companies, were not met by a majority of plans in a state. And these benchmark plans change from state to state to state. And also that drug doses and forms of the same treatment varied greatly. So what this means is that, for example, entecavir, 100 milligrams could be priced on tier 4, and yet 300 milligrams for entecavir can be placed on tier 2. And I know that sounds backwards because 100 is on the higher end, even though it's less. But sometimes these treatments may cost more in different forms and dosages, and that is why we're speculating that insurance companies are placing the same dose and form of the same treatment on different tiers. Next slide, please. And so other common barriers to access that we saw are prior authorization, so basically requiring a physician sign-off for generic drugs and first-line treatments. We saw a lot of states included no mail order options, depending upon the tier or sometimes the drug. So for higher tiers, sometimes there were no mail order options because they were considered those specialty treatments. And if there were higher costs for those mail order options, often 2 to 3 times the price of the retail treatment. And this is also significant because not everybody lives near a pharmacy that in the United States, we have people with hepatitis B who are living in more rural areas, and they have to travel far to access it. And so mail order options can be very helpful, especially if you have a disability and you can't leave the house as often to get your medication or treatment. So there's a number of different reasons why mail order is significant and should be included. Next slide, please. And so for those of you who are living with hepatitis B or who know individuals who might need assistance with paying for these treatments, there are fortunately some resources out there to help you. So for Vemlidy and entecavir, you can go to the manufacturer's website. Most of the time, insurance must be had though in order to access it. For all medications, you can access these four listed. So GoodRx will take you to the prescription. It will show you the cheapest prescription based upon the pharmacy in your area. If you type in your zip code and the treatment. RX Outreach and Prescription Hope are two different ones. However, these are nonprofit mail order pharmacies. For RX Outreach, an individual can access tenofovir for $25 a month and entecavir for $45 a month. And with Prescription Hope, you can access all three first-line treatments, so Vemlidy, tenofovir, and entecavir for just $50 a month. And for both of those, insurance is not needed. So if you're underinsured or don't have any insurance, you can just go to those websites and type in your eligibility, and it'll be based upon income, and you'll be able to apply that way. And some additional resources for if you will need more information about treatment or just treatment access issues, you can go to our website at www.hepb.org, and a list of treatments underneath there. Next slide, please. And so the major conclusions and takeaways from this presentation are that despite the Affordable Care Act, adverse drug tearing is occurring in multiple states. There is no federal definition for specialty drugs. So this is decided upon the states and insurance carriers' discretion. And this is really significant because it basically changes from state to state. So if you lived in California and you move to Pennsylvania, your treatment access can change drastically. So these medications need to be taken daily. If individuals stop taking them because they can't afford them, this can be extremely damaging to their liver. We've had calls from people saying that they can no longer afford their medication, so they're splitting pills in half, and they're not taking correct dosages, or they've had to stop taking it for weeks at a time because they're choosing between food or their rent and medication. And insurance companies can change their formularies throughout the year. So depending upon how they change the formularies, they can shift your treatment from tier 1 in the beginning of the year when you sign up to tier 3 or 4 halfway through the year or whatever time. And you're stuck with formularies through that year. So it's really important to be aware of that. And in general, it's very important for hepatitis B medications to be both affordable and accessible. Next slide is just my contact information and the Hepatitis B Foundation's consult helpline, where we'll answer any questions regarding hepatitis B. Thank you.
Great. Thanks so much, Michaela. That was really helpful information. And this is just a reminder for everyone, if you have questions, please continue to send them via the chat box, and we will go through them at the conclusion of the presentation. And now we'll turn it over to Rachel Klein, and she will delve a little deeper into other aspects of discriminatory practices. Cool.
Hi, thank you so much. Sorry, I was on mute. But thank you very much for inviting me to join this presentation today. I'm very excited to talk to everyone about Copay accumulators, which is a policy that has a very, very strange name that actually does not have anything to do with what it actually does. And so I want to go over what we know about Copay accumulators. What are they? How do they work? How do they affect patients? And what we can do about it. If you can go to the next slide. And then one after that. Thanks so much. Okay, so let's just jump right into it. What is a Copay accumulator? This is basically a policy that is adopted by insurance companies or pharmacy benefit managers that basically says that if a patient relies on copay assistance, which is some of what Michaela was just talking about, help to afford the often very steep copays or coinsurance that patients have to pay, particularly for specialty medications, the insurance companies are frustrated that patients are using copay assistance to sort of get around the policies that they're putting in place around coinsurance and how much they want patients to pay out of pocket for their share of their medication costs. And so they've put these policies into place that basically enable them to not count that copay assistance towards the deductible, or this slide says OOP, but for folks on the phone, that is an out-of-pocket limit, which is an acronym we often use, OOP, as out-of-pocket. So the cost-sharing limits that exist in health insurance are a maximum amount of money that people will have to pay out of pocket in a given year towards their health care. So when an insurance company has a copay accumulator in place, it's basically saying, okay, we will accept that amount of money that is being paid as coinsurance for this medication, but because you're using copay assistance from a manufacturer, we're not going to count it towards your deductible or your out-of-pocket limit. This is not allowed in Medicaid or the Children's Health Insurance Program or in Medicare, but it is increasingly being adopted amongst private health insurance plans, and particularly with employer plans, where the majority of Americans get their health insurance. Next slide, please. So if you're looking for this language in a particular insurance plan, it's going to be a little bit hard to find. The language is kind of complicated, and it's often buried in an insurance plan's certificate of coverage or the evidence of coverage document or the contract with enrollees. And occasionally it's in the summary of benefits document, which is a shortened version of all of the rules about what will be covered and not covered and under what circumstances, and how much you'll pay for that. But very few insurers actually put their copay accumulator language into a summary of benefits document. Instead, you have to kind of look through these very long and very detailed documents with lots of fine print in order to figure out whether or not the plan that you're enrolled in or thinking about signing up for has a copay accumulator. And this slide gives you some examples in those three boxes of what that language might actually say. And there's a few different ways that this could be phrased. Sometimes the insurance company will say, this is a copay accumulator. Sometimes they will not. And they may use language that says very clearly, we're not going to count any money that you get from a manufacturer in the form of of copay assistance towards your deductible or towards your out-of-pocket maximum. But sometimes they might use language that's a little bit harder to parse. So since we're nearing the end of open enrollment season, but we are still in the midst of open enrollment for plans through the Affordable Care Act. Some of you may be working with patients who are looking for coverage, and this is something definitely to look for if you have a patient who relies on, or a family member who relies on specialty drugs, just to at least know in advance whether the insurance plan that they're looking at will or will not include this. Next slide, please. Okay, so how does it work? It's actually a fairly simple concept, but I've got a couple of slides here just to show how, what does this mean for the patient and what does it mean at different points in time. So in this example, the patient has a $1,000 deductible and has copay assistance of $500 from the manufacturer for the prescription drugs that they take. If they're in a plan that does not have a copay accumulator, they will go to the pharmacy, they will present their copay assistance card or coupon or whatever they have to the pharmacy. They will get their prescription drug and they will have used up, so to speak, a half, $500 of their $1,000 deductible, which means that they will, in order to meet their deductible to get other health care or other prescription drugs, they will have $500 remaining, and then they will have met their deductible. If they are in a plan that has a copay accumulator, that $500 for copay assistance will enable them to get their prescription drug, but it will not count towards the deductible, which means that they will still have $1,000 remaining to reach that deductible. And the important part is that we'll talk about what it means in terms of the actual patient, and their ability to get their prescription drugs. However, the important thing is that patients don't always know when they go to the counter and they're presenting their coupon that it's not counting towards their deductible, and so they can be very surprised at some point during the year when they are hit with a larger bill. If you'll go to the next slide, we can dive more into that. So this is an example, and I have 2 slides here. So with this very detailed chart that I know, and I apologize, has very small print in it, but what you can basically see here is an example of what it looks like when you're getting a prescription drug and it's covered by a plan that does not have a copay accumulator. So we would sort of consider this as like, the standard way we're used to insurance working, right? You go to the pharmacy and you'll see you have your copay assistance maximum. In this case, we've used an example where the patient has a deductible of $4,400. They have a 50% coinsurance after their deductible is met. The medication costs $1,675. There's an out-of-pocket maximum of $7,900, and I'm sorry, there's just a lot of numbers, and manufacturer copay assistance maximum of $7,200. So if you look at the chart, you can sort of see in that first row, here's what's happening with the consumer. They aren't paying anything out of pocket because they're using their copay assistance for the first, in this case, 6 months of the year. And so when they go to the pharmacy counter, they're getting their medication, they're handing the card over, and that's that. It's because the copay assistance is covering the cost of their coinsurance. Then there's a point in time during the year, around the middle of the year, where they will have to pay out of pocket part of the coinsurance because their copay assistance card doesn't cover the entire cost for the whole year of their drug. And at the same time, you'll see on that bottom row that they are going through their deductible so that other healthcare costs are going to be counted as for their co-payment and coinsurance. They won't have to pay the full freight, but they'll be paying just their share of it because that copay assistance card is taking care of the coinsurance for their medication. Can you go to the next slide, please? What you can see in this chart is that the scenario is now very different for the consumer. They are still using their coinsurance card, their copay assistance card, which in this instance gets them through, they're getting their drugs for, without having to pay out of pocket through April. But then all of a sudden they go in May and they're hit with a very large bill for that medication because the copay assistance hasn't been counted towards their deductible. So there's a significant cost for patients out of pocket, and where they encounter that is at the pharmacy counter. Can you go to the next slide? So this is a serious issue for many patients, particularly those who have chronic conditions and rely on specialty medication. In general, we are seeing just in health insurance across the country, and particularly employer-sponsored coverage. This is data from the Kaiser Family Foundation that does an annual survey every year of employer plans. And what they have found is that in the last 10 years, deductibles and premiums, but in this case, the deductible line, that yellow one at the top is the particularly important one, have been increasing rapidly as the insurers have been designing their plans with higher and higher deductibles for people to meet before the coverage actually kicks in. And you can see with this chart is that those deductibles have been going up significantly faster than have worker earnings or inflation over the last 10 years. So there's been moderate increases overall in worker earnings, but there have been gigantic increases in deductibles, meaning that people are faced with a greater burden to pay out of pocket for medication that they're relying on until they meet that deductible and the coverage actually kicks in. Oh, can you go to the next slide, please? And that matters for patients. This is another study that data from the Kaiser Family Foundation that shows that when people are faced with higher costs for their prescription drugs, because either the cost of the drug has gone up, the cost of their coinsurance has gone up, or their deductible has gone up, they tend to not fill that prescription or walk away from their treatment. And clearly that is happening across the board, but it's happening in greater instances amongst people with chronic conditions, especially those who tend to rely on specialty medications that insurers are charging more for. Can you move to the next slide, please? So in recognition of this problem, the federal government in 2019 issued the 2020 Notice of Benefit and Payment Parameters, which we affectionately refer to as the NBPP, which governs a lot of how insurance companies what different things they can do and can't do around the structure of health insurance. And one of the provisions that was in that rulemaking this year is that for 2020, there was going to be a restriction on how insurance companies and PBMs could use copay accumulators, basically saying that they could only be used where there is an available generic for a particular medication, and where the patient hasn't gained access to a brand name drug because of the appeals process or exceptions policy in that insurance plan. For HIV medication, we really don't have any approved generics, so this was a significant improvement for our population. And for several other conditions where there are newer drugs that are still a brand name without a generic competitor. So this would have severely restricted the use of copay accumulators across the board. Most copay assistance is offered by manufacturers for brand name drugs that do not have a generic. So again, this would have been a really important win for us. However, a few months after HHS announced this new policy, they announced that they would not be enforcing it for 2020 and that they will be revisiting the policy in the 2021 Notice of Benefit and Payment Parameters. We're expecting to see that proposed rule any day now. I've been hearing rumors for a couple weeks that it's happening today or tomorrow, and we haven't seen it yet, although it is usually out before the end of the year. So we're hopeful that we will see that policy and see if HHS has indeed made any changes to it, or if they will be going ahead and enforcing the rule as it was printed in last year's notice. So you should stay tuned because there's going to be a lot more activity on this front federally. But in the meantime, if you can go to the next slide. In the absence of federal rules limiting or restricting or prohibiting how insurance companies and PBMs can use copay accumulators, there are a few states that have stepped up to protect the patients who live in their states. Last year, there were 4 states that passed legislation that require insurers to count all of the money they receive for cost sharing towards deductibles and out-of-pocket limits, regardless of where the original source of that funding was. And those states are Arizona, Illinois, West Virginia, and Virginia. That's in alphabetical order, but Virginia was actually the first state that passed that law, followed by West Virginia, and then Arizona and Illinois. There was a bit of momentum as state legislatures wound down last year with this legislation being introduced in a number of states across the country. And a few of those efforts are still ongoing. For example, in Pennsylvania, there is a bill that is still live there that is making its way through the state legislature. There's also some action in Ohio, North Carolina, and Florida that we've heard of, either pending legislation in the 2019 legislative session, if those are still ongoing, or in states where they have a partial year legislative session. Many of those sessions will start again in January, and we know that there are legislators who are poised to introduce legislation or already have. So we expect that that list is going to grow longer, and our hope is that more states will be taking on this cause and protecting patients to make sure that they can afford their medication. Can you move to the next slide? So in the meantime, some of you may be working with patients who are experiencing a problem because of a copay accumulator in their policy. And there are some things that you can do. First of all, if you're working with a patient who's trying to choose their plan for next year as we make our way towards the end of this open enrollment period for ACA coverage, it would be really important to talk with those patients about whether they use a specialty medication that's likely to have a very high coinsurance, or to have copay assistance available from a manufacturer. And if that patient does use copay assistance, to talk with them about this new thing that insurers are doing, and to work with them to help them find out if the plan that they have or the one that they're considering has this policy in it, so that at least they're not surprised when they go to the pharmacy counter to get their medication after the value of their copay assistance has run out and are hit with a very large bill, or have some other healthcare issue that they thought would be covered but isn't because their deductible hasn't been met yet. So to avoid that surprise, you can look through the plan documents, or the fastest thing probably to do is to just call the plan's customer service line and ask them, do they have a policy that enables them to not count that copay assistance towards the deductible or out-of-pocket limits for enrollees. If you are working with someone who has experienced a problem with a copay accumulator policy, you can always file a complaint with their state insurance commissioner. They can file the complaint and you can help them do that. We really want insurance commissioners across the country to hear what this is doing to patients, because they can take action even without state legislation to regulate the insurance plans in their state, and say that they won't allow them to use copay accumulators. Even though HHS is not enforcing that notice of benefit and payment parameters rule this coming year, states can, it doesn't go away. It just means that HHS isn't going to take action on it. States can still enforce that rule because it remains on the books. So that state insurance commissioners can take independent action. And of course, states can also pass legislation to ensure that the plans available in a state do not include a copay accumulator, and they can pass similar legislation, which is very straightforward, a couple of sentences that says insurance companies have to, count the value of copay assistance, regardless of where it comes from, towards a deductible or an out-of-pocket limit. And we have copies of the legislation that have passed in other states and are happy to share that with anyone. If you are interested in working on this in your state, we'd love to be a partner and help you with that effort. Can you go to the next slide? And I think that's all I have. So I'm happy to turn it back over to Kate. And if anyone has questions, I'm happy to answer them. And this is how you can get in touch with me.
Thank you so much, Rachel. It does sound promising in terms of the issue around copay accumulators. It's great seeing states take the initiative to address this on their own, but hopefully the federal government will also take action within the next year or two.
We sure hope so.
Yeah. So I will now open it up for questions for Michaela and Rachel. So feel free to continue to send them in. And we do have a few that have been submitted while the presentation is going on. First, this is a common question, if the slides will be available. Yes, we will post the slides, make them available to you on our website, and also be sent to you via email if you register for the webinar. Question for, I think this is for Michaela. The question is for the costs that people were calling in to HBF about. Were those higher payments the norm, or are those highlights of like the worst case scenario?
So that's a really good question. These are actually the norm of what we're getting. And it's important to remember that, you know, HBF only receives calls people who find us. So there's a large portion of people out there who might be going through the same thing, but they don't know about us in the U.S. And so these large costs are quite frankly the norm. There are some that might be smaller, so people just are looking for patient assistance. And for the most part, this is the average.
Thank you. The next question is, and for either Rachel or Michaela, on either of these issues, can you talk a little bit about Medicaid, Medicare plans, and their role in the tiering or in the copay assistance issues?
Sure. So for Medicaid and Medicare, that is kind of a fine line topic. For certain patient assistance programs, namely some of the ones off the top of my head are ones by the manufacturers. You won't be able to access them if you're on Medicaid or Medicare. And some of the other ones you will actually need to look into as well. Those that are just based, I believe, on income will allow you to. So our outreach and prescription hope will, allow you to do that. But Rachel, do you have anything to add to that?
Hi, can you hear me?
Yeah.
Oh, great. I'm sorry, I got dropped from the call and had to call back in. So I apologize for not hearing your response, Michaela. And can you repeat the question, Kate?
Sure. Can you talk a little bit about Medicare and Medicaid plans and their role in these types of practices and copay assistance?
Yeah, sure. So, very briefly, because I'm sure that Michaela covered a lot the really important stuff. As far as copay accumulators, they're not allowed in Medicare or Medicaid. And in Medicaid, the copayments are very strictly limited. So they're nominal. So this shouldn't be an issue in terms of Medicaid or the Children's Health Insurance Program. And in Medicare, there are rules that protect access to certain classes of medication. HIV drugs are among them. There are 6 protected classes. There may still be co-insurance issues that could make drugs too expensive for people. There is legislation that has been introduced in both the House and the Senate that would cap the amount that people who are on Medicare have to pay for prescription drugs, and would restructure the Medicare Part D program. I hope that you didn't already cover that, Michaela. I'm not being too duplicative. And we're waiting to see what will happen with that. But if that legislation passes, which we hope that it will, either, probably this would be next year because we're running to the end of Congress for this year, then that will place a limit and will really help ensure that people can afford their drugs in Medicare.
Thank you. That was really helpful. Thank you, Beth. The next question has to do with the Copay assistance programs. Just a couple of questions. One, do you know if there's a citizenship requirement for RX Hope or Prescription Hope? And then related to that, what is the income, if you know what the income requirement is to access the prescription assistance program?
Sure. So for RX Outreach and Prescription Hope, they're pretty much just based upon the eligibility is based upon your income. And I believe for RX Outreach, it's about 40% below, 400% below the poverty level. So a lot of people are actually eligible for it. The one thing to note, however, with these programs are that you do need at least, a primary care provider or some kind of physician for the prescription itself in general, which most people already have, but just as a note for that. And what was the second part of the question, Kate?
If you know if they ask about citizenship, like if you have to be a U.S. citizen.
Oh, right. No. And so all of this information, since I know it might be a lot to take in, they have FAQ pages on their website that will cover this as well. But yeah, no. Just another note is that you can have insurance as well for these programs. So again, a lot of people are eligible.
That is helpful. Thank you. And then moving on, we have a few questions related to advocacy around drug tiering and Copay accumulators. First is, are there any examples of providers or organizations writing advocacy letters in these states to change the medication coverage to lower tiers? Michaela, if you want to share some of the plans, and Rachel, if you also want to talk about some of the AIDS Institute's work as well, that would be helpful.
Sure. Yeah, so the Hepatitis Foundation, that's something that we're actually working on. So the next steps for us are completing some states for the 2020 analysis to really solidify what we've been talking about and what we've been learning. Some plans do change each year, and we just want to make sure that we're creating the right case. And so we started back in July with our summit with, approaching our partners at Hep B United and making them aware of this issue. And a lot of them are really passionate. The only thing is that this is a state level issue. So it will take time, which is something to note. And that if anybody, has clients or patients who are experiencing this type of discrimination, you should always bring it up to the state insurance commissioner, which will help drive the case that this is happening. Rachel?
Yeah, I would just add that that the AIDS Institute has worked with other organizations, and I think that you referred to some of what we have done in your presentation, where we found that there was adverse tiering going on in Florida, and filed lawsuit there that asserted that the companies were discriminating against people with HIV. And as a result of that, there are some rules that have been adopted in Florida about the tiering for HIV medications. So, and we monitor what that looks like. In terms of, and I don't think, everyone doesn't always have the ability to sue, right, when you find that there's something wrong going on. And I think that I heard specifically question about were there providers engaged in advocacy. And we've had a number of instances where we've engaged with different providers to be talking about these issues. It's actually a very effective advocacy strategy because healthcare providers are very well respected by state legislatures and by members of Congress. And when they can come and talk about what happens to their patients when they can't get their medication, or the struggles their patients are going through because of the way that the benefits are structured in insurance, or because of policies like copay accumulators, it can have a really powerful effect. So if you are in a state where there's pending legislation, or you hope that there will be pending legislation about banning copay accumulators, requiring insurers to accept and count the money that they are collecting towards copayments, toward the out-of-pocket limit, having providers speak to what their patients are experiencing is a very, very powerful tool, and that can happen in the form of visits with legislators, visits with the insurance commissioner, letters to the editor, op-eds that get published in state or statewide or a local paper. There's a whole lot of different ways. Collecting stories from patients is crucial to getting these bills passed and to changing the policy, particularly around copay accumulators. So if you are in a position where you know providers who are willing to do that, or you have patients who are experiencing these problems, working with them to collect their stories and share them is an incredibly powerful advocacy tool, and I would be happy to help if you would like to do that.
I agree, and I also just wanted to mention briefly, since I know a lot of you also, multiple diseases. So the Center for Health Law and Policy Innovation is also working on similar analysis, but for hepatitis C. So if that's something that you're interested in, you can also reach out to them for more information.
Thank you. So we have the last couple of questions. This one is for Rachel. So an advocate from California is wondering where California is in the copay accumulator legislation process.
We're actually doing a review right now of the 2020 plans in a whole lot of states, including California. And I don't have the results of it in front of me, but I'm happy, if you want to follow up with me, shoot me an email or give me a call, and I'm happy to share that with you.
And I just put Rachel's contact information up on the screen again if you'd like to get in touch directly. Thanks so much. So there was a question around if this is happening, it's legal under the Affordable Care Act, why hasn't it been taken to the fights in the courts? And I think you both have covered that a little bit. Rachel most recently saying not everyone has the resources to take this to litigation, but there is a great example where the AIDS Institute did take this to the court in Florida, and it was kind of, as I understand, a perfect storm where you had champions at the state level with the governor and the health insurance commissioner, and were able to reach a settlement agreement and get that particular insurance company to change their practices. So I think that is the ultimate goal, to call these insurers out and take them to court. And so I know at the Hepatitis B Foundation, that is the ultimate goal, and we will have to, within our capacity, tackle that state by state. And if there are any state advocates out there on this webinar, if you know of anyone that would be interested in working together with us, please do get in touch, and that's something that we would be excited to work on with you. All right, so looks like we are at time, and if there were any questions that have come up recently, or if we were unable to address them during the Q&A, please feel free to send them via email at connect@hepunited.org, and we'll be sure to answer them or direct them to Michaela or Rachel. I wanted to thank both Michaela and Rachel so much for sharing your great work on the advocacy work that you're doing to make a change in the health system. And I hope that this webinar was helpful for everyone if you're someone who's looking at changing your health insurance plan or buying one at the federal exchange, or if you're helping a patient navigate through this very complicated process. Hopefully this gives you some things to look out for. And we look forward to doing the same analysis as Michaela mentioned in 2020 and come up with even better trends and data in future years. Lastly, I'd like to invite everyone to complete an online evaluation to provide your feedback about your participation in the webinar when you exit the webinar today. So thank you again and have a great day.
Thank you.
Thanks.